And so access, yes, we have these two methods, as you know. Originally, it was always surgically, but then we developed this percutaneous technique, and I will go into some of the details. Before you start with that, naturally, you have to know not only size and location of the aneurysm and the distance to the neighboring arteries, especially the renal arteries, but you must include in your CTA also the femoral area in this case, because you want to use these artery as access vessel, and so you have to know how does it look like. Yes, when we look at the mortality, yes, open surgical repair is in the range of 4 to 5%. Evar is much lower, below 2%. And you see, yes, when it has ruptured, even then, Evar is a little bit better than open repair. So today, we can say Evar is a preferred treatment method for abdominal aortic aneurysms. So open versus percutaneous means, yes, you have to prepare the artery, and at the end also you have to close by a suture the access side of the femoral artery. The other one is you puncture it. Sometimes it's helpful, as you have already seen, also to use ultrasound to hit the anterior wall and not only somewhere, but in the middle of the anterior wall, it's best. We have, in the meanwhile, several closure devices, and that allowed us to use these percutaneous access. I prefer, yes, often two systems, which I turn the next one by 45 degrees, so I have 4 needles coming out. And we have the advantage that over the years, yes, the endografts were becoming smaller and smaller. So we started with 24 French, and now we have systems down to 14 and 16. So that is very helpful. And at the end of the procedure, yes, you see the puncture sites, and the patient is feeling well, and it's very uncomplicated. It was first done in 1999. Today, more than half of them are done percutaneously. The advantages are clear. No general anesthesia, no intensive care unit afterwards, shorter hospital stay, more economic. There are limitations, as with every method. So when it's heavily calcified, common femoral artery, then you have to look very carefully if it's not better to go with a surgical technique. Because you have not only to puncture, but you have then to introduce through this calcified wall also a fairly thick catheter. And it's possible also that the closure device will fail. Luckily, most calcifications are on the rear wall, but you can also have circular calcifications, and that is limiting the Pevar technique. So we have our evaluation included 314 patients with Evar versus Pevar. We excluded patients who already had an aortic procedure beforehand. The risk factors are listed here. Typical factors, yes, you know that these people are smokers and are hypertensive and have also an impaired lipid metabolism. Significant difference was, yes, we had much more hypertensive patients in the group of Pevar. And you see here the complications, vascular complications, yes, Pevar more than Evar. Wound infection the same. Closure failure, we had one case where we had then to occlude it with surgical means. Intervention time was shorter, as you see, on the mean than with open. You can expect that because you have to prepare the artery and then you have to do a suture at the end. The difference is statistically significant in favor of Pevar. But also radiation exposure was less with Pevar. Also that is statistically significant. Hospital stay also was influenced, so you had much less time the patient in the hospital, so that's also saving some money. That's also statistically significant difference. So I conclude, Pevar depends on the experience of the interventionalist, but that's true for all interventions. Pevar is superior concerning intervention time, radiation exposure, and hospital stay, at least in our group. And it is essential, yes, that you check by ultrasound and CT the condition of the access vessel. Thank you very much.
Thank you very much. Any comments from the audience? Any questions? While we're waiting for someone, how come that you have 2 infections in the percutaneous? Do you have any explanation?
Yes, it's not easy to explain it, yes, but it happened. I have no real convincing answer for that. Yes, I must invent something then.
Yeah.
No. So that it happened. The complications, yes, I showed it's not a high percentage, it's a low percentage, but it happens, yes, and that can be either you have not properly occluded it and you have the impression, oh, everything is very well, but later on when you do the patient feels some pain or you do some ultrasound examination, then you see, oh, there is a little bit of bulging there and perhaps a small pseudoaneurysm and so on. So that can happen there.
Professor Busquet, do you perform fevers on the percutaneous or?
Percutaneous, but I'm going to tell you more during my presentation.
Because yes, the next presentation
This was
with
my
a very
interest.
similar subject. Yes?
We are very good friends anyway.
Yes, Jacques is wonderful. I like to drink a glass of red wine with him.
Yeah, this was actually my introduction to the next speaker, Professor Busquet, with the topic Pevar versus fever.